Hello, everyone. We'll be starting the panel on unspoken topics in survivorship now. Welcome, and thank you for being here and being open to having this conversation with us. My name is Tara Rick, and I'll be moderating this session. I'm a PA in adult oncology at the University of Minnesota, so M Health Fairview, and I see cancer survivors in my survivorship or long-term follow-up clinic. So this is a panel discussion, as you've been on other panel discussions, probably in the breakouts. And there will be opportunities to submit your questions to the panelists. So please enter your questions and comments in the question and answer function at any time as your questions come up. It's anonymous, so only the host and the panelists will be able to see your full name and your question. We have some great panelists today. We have Mike Neeson, Kathy Washburn, and Kirsten Mulvey. Mike was diagnosed with stage 4 colorectal cancer in 2008 when he was 45 years old. He had surgery in 2009 to remove the cancer and create 2 ostomies. He has a colostomy and a urostomy. And since his recovery, he has spent a lot of time volunteering with cancer and ostomy patients and has been running his colon cancer charity. And I think Mike is joining us from sunny California. So welcome, Mike.
Thanks.
And Kathy is a life coach who works with individuals navigating life's most challenging transitions. In this second career, her education and interest in positive psychology, post-traumatic growth, and narrative therapy combined to form her unique approach to personal and professional coaching. Kathy experienced advanced stage vulvar cancer and was treated at the University of Minnesota in 2002. Her current passion is to help fill the gap in patient needs during the transition from treatment to life after cancer, and has founded Carved by Cancer, which is a support network for cancer survivors. And welcome, Kathy. And Kirsten is a women's health and adult nurse practitioner who has specialized in gynecologic oncology for the past 15 years. She has a special interest in sexual health and has pursued special certifications on the topic, and is a member of several societies which the focus is on sexual health, and speaks a lot about this topic. In her clinic, she provides survivorship care as well as encourages open discussion regarding sexual health and concerns following a cancer diagnosis and treatment. All right, so you know a little bit about us, and we would like to know a little bit about you with just 2 quick poll questions. The first poll question, we just want to know what your gender identity is. All right, and then the second question is, we just would like to know what kind of concerns are you coming in with today? All right, so we can kind of see the breakdown. So we've got majority male, majority female, some male, and then some non-binary, non-conforming people here as well. And it looks like some of the major concerns are intimacy, connection with a partner, loss of libido, sexual desire, body image, erectile dysfunction, vaginal dryness, pain with intercourse, and some others. Well, you guys are at the right place because we are going to be touching on a majority of these topics. It's a really short period of time to talk about all the things that we want to talk to you about, but at least we can sort of scratch the surface. And I want to start out by saying that sexual changes related to cancer and cancer treatment can be one of the most common and distressing side effects for cancer survivors, and something that's not always talked about. Cancer and treatment can negatively affect both physical and psychological aspects of sexual health, and sexual health can be associated with our overall sense of well-being and connection. Just an example, I've worked with patients for many, many years, and over the years, questions have come up over time, but it wasn't until I made this question, concerns about sexual health, as part of what I always ask everybody about, that I realized that almost everybody had something to say. So I missed a lot of opportunities with people in the past. And I think that just highlights that we have room to go as healthcare providers in normalizing this and introducing this conversation. So let's start with the physical aspects. So cancer treatment, including surgery, radiation, chemo, all the other types of therapies, can have significant direct and indirect effects on sexual health. And I want to hear from all the panelists on your own specific challenges, for you, kind of Mike and Kathy, and then some ways that you've overcome these challenges. And then we'll hear from Kirsten on her experience as a gynecologic oncology nurse practitioner on the topic as well. So Mike, let's start out with you.
Okay, thanks for having me today. And I think I'm going to be able to cover a lot of those topics that came up on the poll questions there. Good or bad, I get to cover a lot of those bases with my diagnosis and my life since my diagnosis and recovery. As Tara said, my story really started back in 2008. I was diagnosed with stage 4 colon cancer. I was 45 years old, had perfect health up until then. Immediately after my diagnosis, my surgeon had told me I'd go through 10 weeks of chemo and radiation in the fall of 2008. I'd get some time off around Christmas to recover, and then I would go in January for surgery, not only to remove the tumor, but then also to create, a colonoscopy or a colostomy, which was obviously a shock to me. But based on the location of my tumor, that was a certainty for me. So I went through the 10 weeks of chemo and radiation in the fall, had my surgery, and the day I actually went in for my surgery, I found out that I was also going to have my bladder removed, which was obviously, a shock and news to me. But the radiation, the 10 weeks of radiation, had done a lot of damage to my bladder, and I was going to have incontinence problems. I'm an incredibly active person. I ski, golf, do an awful lot of things, and so that was going to be a big issue. And so I went into an 11-hour surgery. I came out, totally different body with 2 ostomies. Spent 23 days in the University of Minnesota hospital. And when you're in the hospital, there's a lot of support. But at the end of the 23 days, I went home with my new body, and that was really uncomfortable because that support wasn't there any longer. And, I had to adjust to my body. I had to adjust to the 2 pouches, learn how to change the barriers, things like that. So from a physical perspective, it was incredibly, different. And I also, probably about 3 to 4 weeks after I got home, my oncologist said, we're going to go on to another 26 weeks of chemo. Like I hadn't had enough in the fall. So I had another 26 weeks. So that's spring and summer, I'm starting to slowly go back to work, get back to my life. I complete the chemo by, late summer. Life is starting to get back to normal a little bit. Back to work full time, doing my activities, things like that. By that time, I've adjusted physically, to the both ostomies. I'm golfing, I'm doing things again. But the story didn't unfortunately end there. For those of you who have went through the cancer journey, early on you go through quarterly checkups, scans, blood work, and then semi-annual, and then finally on to annual. But about 2 years into my recovery there, I started to have a cough, and I was going in for my semi-annual checks, but I couldn't shake this cough. And so I went in a little early ahead of time. And sure enough, the colon cancer had metastasized to my lungs. And actually I had, 5 lobes in your 2 lungs, and I actually had a node or a tumor in every single one of my lobes. And one of them had started to grow pretty aggressively. So I had a lobectomy to remove that. But I was in one day, literally in the hospital, and out the next evening. So it was nothing like the 23-day adventure I had prior. And so I met with my oncologist shortly after that, and he asked how it was going. I said, actually pretty well. It wasn't too painful, and I was in and out fairly quick, 48 hours. And he said, well, I'm glad to hear that and that you're doing well, because we're going to start, I'm not kidding you, another 26 weeks of chemo. So now, this is, my 3rd long cycle of chemo. So when you talk about physical effects of neuropathy and radiation, obviously I was experiencing those. And so before I can even finish the 26 weeks of chemo after the lobectomy, I started to have brutal kidney pain. And so I went in, and what happened is all of us have, for the most part, right, have two kidneys, and then you have what are called ureters. They're like straws, if you think of it, that drain your kidneys for the urine. And what had happened from all the radiation, I had strictures, or if you think of it, kinks in those ureters. So the urine couldn't get out of my kidneys and through these straw-like ureters. And so my urology surgeon had explained that they were going to put stents in, which made sense to me, right? I told him, I get the concept of putting a stent in kind of like a straw to keep it open. And I'm not kidding you. I remember telling him, like this, like a 1 inch, I golf with some guys who have heart stents. I've obviously never seen them, but I remember, making this kind of motion. I'm like, yeah, I get the concept, of a stent. And he said, I don't think you do. He said, these are 16 inches long. You're going to have 2 of them, and we're going to change them every 60 days for the rest of your life. I'm like, yep, you're right. I didn't understand the concept of stents. So when Tara talks about, the physical effects of cancer, I've been through my cancer. It'll be 14 years this fall. And I lead a really active life, but it's not, even with the cancer gone, it's not to say there isn't collateral damage. I have, issues, small issues from being on chemo 62 weeks over that couple of years. The stints I go in, every 50 days, to have them changed. And I have the 2 ostomies. So I have a lot of physical changes. But when it comes to intimacy, and I want to talk about that because that's the topic of today's discussion. So, I saw maybe 20% of the attendees, are male, and maybe 80% female, and some non-binary. Excuse me. But what I want to talk about that, and is that first 2 years, between all the chemo, all the radiation, all the healing, the surgeries. I'll tell you, no surprise, my energy level and desire and will for any real heavy physical intimacy was incredibly low. And I think my wife understood that, but that didn't necessarily make it easier. We had been married probably 18 years, 17 years at that time. But, I felt bad for her, but I just, that was not something very frequently I was just in the mood or physically from my energy or stamina, able to do. But what I want to share, is that, even if you can't have that heavy intimacy, that's not everything, I guess. And the most important thing is to talk to your partner or spouse, because, we found ways of just, it could have been hugging, it could have been holding hands, it could have been kissing. You can have, a very committed relationship, have a lot of different intimacy that keeps that relationship strong when you aren't able, to maybe have, what you think of sometimes as the heavy passion in the bedroom. And so I just think talking is so important, and you can find other ways, but without that communication, I think it's going to be, you're just adding on to a really, really difficult situation. And never assume that your spouse or partner, is maybe on the same page as you or totally understands. And that's why I can't stress enough the communication. And the second half of my talk here in a little bit, I'll talk a little bit more, about kind of that partner relationship and expectations and how you view yourself. And maybe that might not be accurate. Tara?
Thank you so much, Mike, for sharing. And we look forward to hearing more in depth about kind of some of these topics as well. And Kathy, I want to turn it over to you to share your journey and your experience from the physical side.
Yes, thank you, Tara. And thank you, Mike, for kind of kicking that off. So the physical effects after my treatment were daunting, actually. I was 34 years old. I was the mother of 2 young children, been married for 12 years. I was thrown into menopause. I had a radical vulvectomy and radiation, which changed the way I looked. Sex was extraordinarily painful. And I had issues with bladder control, as Mike highlighted, from radiation. It was as if I was actually walking in somebody else's body. I just felt completely disconnected. And I didn't feel I had any control over what was happening. And I have to say, it was an extraordinarily lonely time. I didn't talk about my problems to the people closest to me. I didn't want them to worry about me. I didn't want anybody to think I was still broken or I was broken. And I felt like I had so much to be grateful for just to be alive that I didn't warrant any complaining about how I was alive. So it actually took me years to seek the help that I needed to understand how my body functioned differently. And I want to highlight that it functions differently. It does not dysfunction. I think often people refer to dysfunction, and I don't think that's fair. But I've worked with so many therapists in the last 5 years, pelvic floor therapists, sex therapists, regular therapists, as well as specialists like a urogynecologist and a vulvar dermatologist to actually learn about the body that I walk in and how it functions. This is help and work that I wished I had done after cancer. And I know there's so many options now for people. This was 20 years ago. And I'm so excited to hear Kirsten and both Kirsten and yourself talk about that, Tara, because it's work that I wished I had done then, maybe even wished I had done before cancer, but that's beside the fact. The other side effect was lymphedema. And this was different because my doctor actually sent me to a lymphedema therapist before my surgery. This would now fall into this category of prehab, which is something that I'm very passionate about because I experienced the power of it in retrospect. I met with a lymphedema therapist who told me what was actually going to happen in my body. And she prepared me for helping me reroute the lymph system before the surgery even happened. So I had some control over this and I felt like I was part of this. I took a class on skin brushing at a place called Pathways in Minnesota that offered that. So I was very invested in that before the surgery. And I have to tell you, to this day, I skin brush every morning before my shower. I continue that work. So I do not have any lymphedema issues. It appears in the summertime when it's really hot out. But that prehab was very, very powerful to me that I'm understanding that now. And the indirect or not visible effect to me, I think, was grief. I did not process losses associated to cancer. And my God, there were many. But there was no invitation to grieve between treatment and getting back to normal. And so I just skipped that. But what I've learned in the last 5 years, especially, is unprocessed emotions don't go away. Stuffing emotions, they don't disappear. They just eke out sometimes in unhealthy ways. So I did find solace in group therapy that centered around the release of the losses that I had been carrying for the prior 15 years. So those are the things that come up for me when you ask the question from the side effects.
And what's interesting, what I'm hearing from both of you is we're talking about physical, but we float between physical and psychological. Nothing's purely physical, when it comes to sexual health, and nothing's purely psychological. It's a complex mix of the both. And Kirsten, can you kind of comment on some of the common physical manifestations that you see with your patients, and what are some solutions that you recommend?
Yeah, so I was going to talk about some possible, impacts you can see from surgery, chemotherapy, radiation, or even some medications, and how that can impact sexual health. Surgery for cancer, of course, can include removing body parts you can see, like breasts, but it can also include parts that you can't see, like a uterus, a cervix, or sections of a bowel. It can result in drains, tubes, bags, scars, slow healing wounds, and body changes, which can also include the sewing closed of the vagina or the rectum. All of this, of course, can lead to body image concerns, not feeling whole or sexy, like that was already mentioned. And while drains, tubes, and even bags can be temporary in some instances, incisions and scars will heal and gradually fade with time. But of course, that's really difficult to think of at that time when you're living right at that post-surgical moment. Surgery for gynecologic cancer can place a woman into menopause, which of course can lead to all the fun things. Hot flashes, night sweats, vaginal and vulvar dryness, and of course low libido, like has already been discussed. Kathy did a great job of discussing lymphedema, and that's certainly, I've seen an improvement over the last even 5 years in treatment options and really sending women, since I deal with women, I'll say women, but of course men would be the same, to lymphedema therapists, which can be very helpful. Hot flashes and night sweats can be managed by both non-hormonal and hormonal options. Non-hormonal options are always one that you should try first. For hot flashes and night sweats, it can include low-dose medications, which we typically think of as being used as mental health medications. Two of them are venlafaxine and paroxetine. However, only paroxetine is actually FDA approved for this use. For the vaginal and vulvar dryness, the use of lubricants, both water-based and silicone-based, can be used. Water-based lubricants tend to rub into the skin quicker, so they don't last as long as silicone lubricants. And of course, they can be used for sexual intercourse as well as with sexual toys. Vulvar dryness can be managed by using organic coconut oil on the tissue. If you ever are in my clinic, you'll know I talk about that a lot and often for women because it's a good choice. Hormonal options can also be used in certain situations, which I'll touch on later. Low libido or a decreased sex drive can be a common concern in postmenopausal women, which of course, again, like Tara mentioned, can have several factors, both mental and physical. Obviously, that loss of estrogen can be one of the physical factors that can contribute to it. Lots of patients undergo chemotherapy as a treatment for their cancer, and there are numerous types of chemotherapy, and they can all have different types of side effects. Common to most of them are nausea, bowel issues, either constipation or diarrhea, fatigue, low counts leading to increased risk for bleeding or infection, and of course, hair loss. None of those sound especially sexy or leading to someone being in the mood for intimacy, but of course, people have to deal with it at the time. There are medications that you can take for managing nausea, bowel issues, and even the low white blood cell count, but having low platelets and leading to that bleeding risk can actually preclude from having any type of sexual intercourse completely due to the risk. Then, of course, there's the common side effect of neuropathy, a numbness and tingling most often in the hands and feet, which can be quite painful and can significantly impact how one's able to use their tactile sensation. There are medications that can be used for neuropathy, but one shouldn't overlook the importance of using lotions and massaging the hands and the feet. This is a good place where I tell people that your partner can come in handy for this, as this type of sort of low-level intimacy can also lead to more intimacy just from that massage. Pelvic radiation is often commonly used for cervical and endometrial cancers. This radiation can include whole pelvic, which basically does just that. It includes a treatment area that is the cervix or the vaginal cuff following a hysterectomy, but it also can impact the bowels and the bladder. And while advances have been made to help decrease the impact on the bowels and the bladder, there can still be side effects of incontinence from both, similar to what Mike mentioned about after his surgery. There's also internal radiation known as brachytherapy. Both types of this radiation can lead to side effects of stenosis, vaginal stenosis, which is a narrowing or shortening of the vagina, as well as a loss of elasticity. Women who receive radiation are given dilators to assist with maintaining the length and width of her vagina, which can aid in sexual intercourse, but also helps when you come in for your speculum exam when we're monitoring for your cancer recurrence. Dilators can come in many forms and materials. They can be a medical grade plastic, which is kind of a harder, firmer type, which is typically what women are given from radiation, or a silicone type, which is usually softer. Lubricants, both water-based and silicone-based, are used on the dilator, but it's also important to remember to use some of that lubricant around the opening into the vagina. And it's also important to note that if you're using a silicone dilator, that you cannot use a silicone lubricant with that. I wanted to touch a little bit on aromatase inhibitors and tamoxifen. Aromatase inhibitors, known as AI, include anastrozole or exemestane, and they're used to treat hormone receptor positive breast cancer. These medications are typically taken for about 5 years, but can have similar, basically menopausal side effects: hot flashes, night sweats, vaginal and vulvar dryness, and that dryness can cause itching. And for that itching, you can again apply that organic coconut oil because it acts as a moisturizer to that area. AIs can also contribute to osteoporosis, so it's important to be monitored by bone density scans. Tamoxifen is another option. It's a selective estrogen receptor modulator that blocks the estrogen tissue in the breast, so it doesn't act like an estrogen, but tamoxifen does act like an estrogen in the uterus, so it can increase the risk for endometrial cancer in women who still have a uterus. Therefore, it's really important for women to monitor for any vaginal bleeding, especially after menopause. Again, if they have a uterus and they're on tamoxifen. This medication is also taken for 5 years, has similar side effects, but tamoxifen does not increase the risk for osteoporosis. Those are kind of the general things. Again, it's kind of a short amount of time to talk about all the physical aspects we can see that women can potentially, and men can potentially have side effects from all their treatments, which of course the goal is to cure their cancer and not have it recur. But again, there are some significant physical side effects that we need to deal with, which I think overall, I think we've been doing much better with in the last 5 years in some areas, 10 years in other areas. But I think it basically comes down to, again, that importance of communication and asking how women are doing during their treatments. So, thank you.
Thank you, Kirsten. And the participants on the call, I mean, hearing all this, you know, there are so many different manifestations, physical manifestations of treatment that can impact your sexual health. So again, want to just bring it up and sort of validate that some of the ways that you are feeling, some of those concerns that you put up, you know, there are reasons behind it, but there are also things that can be done. And we very, very briefly just touched on those. And we'll give you some resources moving forward so you can figure out how to improve your own physical symptoms. Now, let's focus now on the psychological aspects of cancer and treatment on sexual health. I think we started a little bit late, and I don't know if we have to end right at noon, but I think we'll just have to be a little bit more brief in this section. But what, you know, some examples could be body image, self-esteem, intimacy, low sexual satisfaction. And again, all these things can result in distress and decreased quality of life. So let's just start with Mike, and then right away transition to Kathy, and then Kirsten on your own experience, and again, some resources that might have been helpful for you.
Sure, I'll go ahead, and I'll keep mine very brief because I want to make sure we have time for a little feedback or questions. So I'll edit mine down a little bit. But you know, I think the most important thing I took away, and still do, right, from a psychological standpoint, right, is what you touched on, is body image. You know, obviously with having 2 ostomies, my body is not the same as it was before. There's not pain or discomfort. It was really a mental issue for me. And, you know, as a guy who was 45 years old and in pretty good physical shape, all of a sudden, you know, the 2 bags when I was being intimate with my wife, it was a big deal in my head. It wasn't in hers, but, you know, I really had trouble kind of getting over that. And I'll kind of say focusing on the matters at hand and not being distracted in the back of my mind by my different body. And I mentioned in my first little update, you know, about communication and how important that is. And I can't stress that enough, because it, I suffered with that for a while. It didn't seem to bother my wife, but, in the back of my mind, I always thought, is she just kind of placating me? But, we had a very serious talk one day, and she said, I don't see the bags or the pouches. I see you, and I couldn't really get over that. But once we really talked about it, and I trust her implicitly. But once we had a very serious talk about that, I sincerely believed her, and she had never given me any reason not to. It was simply, in my head. So it took a while, but I absolutely, got over that. And it's part of me. But I think maybe just like some other, difficulties in life, it could be, scars, it could be different things. I think your spouse or partner, I think you have to trust them. And that's kind of the last word I want to have. You have to trust them. And sometimes I think we make a bigger deal of it than our spouse, or partner, but that communication is key.
Thanks, Mike. I feel like communication is one of the things that I did not have with my husband, who's now my ex-husband. But during that time, it was so hard for me to understand myself. So to be able to communicate to another person about me was not really possible. I talk a lot with my clients about intimacy, and the way I refer to that is into me I see, which is really understanding who I am and what brings me pleasure, so that I can articulate and allow into me you see. So that intimacy, think it really does require that level of communication that Mike is talking about. And again, seek assistance. Do not silently suffer. I silently suffered for 20 years or 15 years. And there were times, I talk a lot about this moment that I ghosted my body. And it was the moment that I disconnected from myself, and it happened during radiation. Somehow the U of M assigned me one of the most handsome radiologists you've ever seen. Of course, at age 34, I wanted that guy to be my vulvar radiologist. But there was a moment where he was putting my legs in the pillows, and I was trying desperately to avoid all eye contact. And then there was one point where he looked at me, and I just had tears streaming down my face. And he said, "I promise you this will get easier." And in my head, I thought, the humiliation of being on this metal table naked, or the actual pain. And that was the moment I ghosted my body. And that stayed with me in the bedroom with my husband. I would literally take myself out of my body in order to be intimate, with the help of lidocaine, and then eventually alcohol, marijuana, whatever it took to get me out of my head and literally out of my body. But that has changed in the last 5 years. After the end of my marriage, I've been on this quest, and I found resources like Ellen Barnard. She owns a called Sexuality Resources in Wisconsin. This will be part of your resources. But she is a sex educator and spent time with me on the phone, introducing me to this vibrating massage wand. And doesn't that sound a whole lot more fun than a white plastic dilator? And it was incredibly helpful. And all of the other pelvic floor therapists, they're angels, and they introduced me and helped me to be into me I see. And then there are, I met Dana Onofree. She's the owner of Ana Ono, which is a lingerie company that specifically offers for cancer survivors a little anchor in finding beauty in the new version of you. And that was just eye-opening to help me feel pretty again, and to help me kind of cross that barrier. I hated being naked. It was horrifying, but now I feel very differently now. So I think combined with what Mike is saying, it's really opening those lines of communication and seeking the help that you need in order to open these doors. And it starts with people like Kirsten and Tara, because they're a safe place where you can express these concerns and they can help direct to the people that you need.
Yes, and I would certainly say that in my clinics, I will try to ask, and bring up sexuality and sexual health with every single patient. I'll quickly go over some of the common things that I typically hear from patients. At following their surgery, when I ask them, they're typically saying things like they're wondering, can they even have sex after they've had surgery or their treatment? Is their vagina now too short to have sex? Will it hurt? Can I still have an orgasm? Like, there's all these questions that they don't know. And oftentimes I hear more and more times that they'll say that their partner also says that they're afraid to have intimacy because they're afraid they're going to hurt her. So there's a lot of, I think, questions that are there, but the communication, again, as we've brought up many, many times, is a very important aspect of that. Things that I'll do in trying to talk to the patients is talk to them about ways that they can have intimacy other than even penetration, or changing positions, again, using dilators, even if you haven't had radiation. There are things, these little soft rings that you can stack on a penis, which can limit the depth of penetration. So women that do have a shorter vagina can still have vaginal penetration. It just is, the depth is limited. And of course, the dilators, yes, like I mentioned, those hard white plastic is typically what you get from the radiation oncologist, but the silicone ones are very popular, and there's a resource listed in there from Sole Source Dilators, and they're a good option. They come in multiple sizes and bright colors, so it's nice to see. And of course, mentioned already is the body image concerns. I think both Kathy and Mike did a really good job covering that. So I don't think I need to talk too much about that, but of course, there's also wigs and prosthetics that can be there as well. And then one other thing is usually that I might hear is that having intimacy is the farthest thing from their mind as they're trying to deal with their cancer diagnosis or their treatment side effects or whatever it may be. So again, it's that communication and talking about ways to manage while they're going through treatment. But of course, it's also important that I always like to point out that these are all common, normal findings for women. It's not, you're not alone. And so I also talk about things that there's many things now in your life that are different. You have mortgages and stresses and work, and, let's face it, you're not 20 years old anymore, so you're more tired, and that plays a part too. So things like, making arrangements for date night, or even as Kathy said, maybe having some alcohol to help kind of relax the mind, because we know the mind and the body have a big relationship together. So it's really important, again, in my role to, again, help normalize the situation and normalize the feelings that they're having, and really stress that there are things that can be done, whether that's seeing a psychologist, seeing a sex therapist, or seeing someone who talks, who focuses on sexual intimacy, that there are options out there and that you're not alone.
Wow. Thank you, panelists, Kathy, Mike, and Kirsten, so much for opening up and sharing these important but often unspoken topics. Like Kirsten says, these conversations are really important to normalize. And I just want to comment that in the chat box, you will find a Word file that you can download onto your own computer if you'd like. And it has some of the resources that our panelists mentioned that were helpful to them, or resources that they recommend to their patients. And also, if you're interested in continuing this conversation, you can find out where your local survivorship clinics are and discuss your specific scenario, and work to come up with an individualized solution for you. Also, Kathy is a resource as well, and her information is in that Word document as well. Now we have just a few minutes, but let's open up this conversation. Maybe we can get one question in. I just want to ask Mike. Mike, when somebody's told that their surgical plan includes an ostomy, they often wonder how much the pouch will impede that. You kind of touched on that, but are there any really practical things that you have that you tell people?
Yeah, I do. And I spend a fair amount of time with ostomy patients pre and post surgery. That's a really common question. Whether you have a ileostomy, colostomy, or urostomy, you can get what are called smaller volume bags. It might be half the size. So my two are probably, 6 inches in length from top to bottom. But during times of intimacy or different activities too, and depending on how much volume you have, you can get kind of low volume bags. They're half the size.
That's helpful to know. Great. Well, I think we're out of time, so let's leave that here. Again, check out some of the resources that we've put out for you. And you can also, again, there are other resources available to you. And we want to thank you guys all for being here, and really, really big thank you for Kathy, Mike, and Mike for being vulnerable and sharing their stories, and for Kirsten for being here and sharing your expertise, and for all that you do in this topic. So thanks, everybody.